is translational research. Recent activities include, for sure, flash therapy. Actually, he led the group who treated the first patient with flash therapy almost 3 years ago. The title of the talk is Clinical Applications of Flash Therapy. Please, Professor Parisi, proceed.
Well, a great thank you for the invitation and for the introduction. Can you see my screen?
Yes, we can.
Oh, fantastic. So I will try to share with you some aspects related to the potential clinical application of flash therapy. These are my disclosures. So we've been listening a lot today about flash. So we are just sort of comparing delivery time in milliseconds versus minutes for conventional dose rates. And this is where we see a difference, as it was shown very nicely by Pierre Montegruel. So now if we want to, let's say, try to use this phenomenon in clinics, the flash effect ideally should be robust, reproducible, clinically meaningful. Also, this effect should be maintained in large volumes of normal tissues, compatible with fractionated radiotherapy, and compatible with high precision radiotherapy delivery that we do every day. So I will try to go through all these items to see where we are at the moment regarding this clinical translation. The first two aspects: is the phenomenon robust enough and reproducible for being used in a clinical setting? And briefly, very briefly, I think it was mentioned before, what about the effect on normal tissues? If we want to summarize on a single slide, we can say that the normal tissue sparing effect with flash compared to conventional has been observed in several types of tissue in mice, in several animal species, and with several types of beam and energy, and also importantly across several institutions. Here is just an example of what has been done in the brain, which is remarkably protected by flash when compared to conventional. I'm not going to detail, I think it was presented before. Also, another area where we have a lot of data is on skin, sparing effect of flash on skin. Here we have data in mice, but also in pig, where we see that the dose modifying factor is around 0.7 for severe toxicity. We will come back to this point later. Now, what about the effect on tumors? I think it was extensively mentioned today with Pierre Montegruel. And what do we see is most of the time ISO effect between conventional and flash, essentially for growth delay, except with one exception, which was mentioned by Pierre on leukemia, human leukemia derived cell line. Now, what about tumor cure? I mean, regrowth delay is something which is nice, but tumor cure obviously is the most important. And here we have very limited data. One interesting data comes from a randomized clinical trial, which was performed in cat patients with the Veterinarian School of Zurich. Here in Lausanne, we've done that. And the comparison was 30 gray in 20 milliseconds, single dose, surface dose. So it was a little more in death. And compared to 48 gray in 10 fractions in 1 week. So when looking at the tumor cure, that is long-term tumor cure, there was one failure in both arms, which is very reassuring. Here we're not talking about growth delay, but really tumor cure in spontaneous cancers. So it seems that here also we see ISO effectiveness. which is a very important message. So in summary, normal tissues, we can say that there is a consistent and reproducible sparing effect with ultra-high dose rate. But as it was mentioned before by Pierre, it was essentially shown in small volumes of normal tissues and with high single dose. Now for tumors, there seems to be isoeffectiveness, but certainly we need more data. So robust, probably yes. Reproducible, I would say yes. But what we don't know is what are the optimal parameters, and there is probably more to know on this. Overall treatment time is probably very important, and you see on this graph the cognitive sparing effect of mice according to the overall treatment time in milliseconds. So if you exceed 100 milliseconds, you may lose a flash effect. Same for the dose per pulse. If you are below 1.5 gray, you see that you start losing the flash effect. It's difficult to say which parameter is the most important because all these parameters are interconnected, and it's hard to say which of them is the most important. Also, the dose rate in the pulse. For pulse irradiation, more than 10 to the 6 gray per second is probably where you certainly see the flash effect the most reproducibly. And finally, the number of pulses. Number of pulses, probably much better to see the effect with less than 10 pulses. It has been shown by Pierre Montegruel, but maybe some suggestion in recent studies that even if you go down to 1 pulse, you can see even more effect. And this is sort of summarized in this complex graph where you see that studies from all around the world where it was shown according to the dose rate in the pulse versus the overall treatment time for delivering 10 gray. And you see that when you are in these conditions here, or more on the right, down and on the right, you probably have a lot of probability to see the flash effect. On the other hand, if you go left and up, you miss the flash effect quite certainly. So reproducible, we can say yes, although we don't know exactly which parameters are important. And then the next question is, all this, is it clinically meaningful? And here, it's important to see what is the magnitude of the benefit of the sparing effect on normal tissues, especially. So I just come back to this skin model. You can see here from pig, mice, and mice, electrons and protons. And when we try to estimate for severe toxicity, what could be the dose modifying factor associated with a flash sparing effect? It's about 0.7. That means that you spare maybe 30% of your dose. But here, look, we have very high dose per fraction, single fraction. So the flash effect is seen in this range of dose for skin. And if we take this example from Soto, you see that for the lower dose, 10 gray to 20 gray, there is relatively minimal differences between normal tissue reactions for conventional and flash, which is related to the fact that these reactions are not severe in both cases. So it's hard to see a difference between conventional and flash in this range of dose. Although we can see here that there is some toxicity. I mean, it's not zero like the control. So there is some toxicity, but it's not different between flash and con. And now, if you look at the higher dose, 30 gray, 40 gray, you see a big difference favoring the flash. And if we try to summarize the data on the skin on this graph, where we see the dose modifying factor on the left, according to the dose which was used for irradiating the mice or the pig, we see that below 20 gray, there is relatively little, if any, difference between flash and conv, and the difference is seen more with 30 gray or more. So these are the studies you see here. And also we had the chance in one patient to compare conventional 15 gray to flash 15 gray given in 90 milliseconds. And as you can see probably on this slide, the reactions that we got were grade 1, both for flash and conventional. And also, importantly, we didn't see a difference in the biopsies taken 2 years after flash and conventional irradiation. So it was done on the same day, everything was the same, except dose rate for 2 lesions. So this paper has been accepted. And when we try to see where do we see this study, well, in fact, it's there. It's 15 gray, it's somewhere in between 10 and 20, but it's very consistent with what was seen in the mouse. That is, in this range of dose, the difference between flash and conv is not big. So is it clinically meaningful? Probably yes, if we are able to use big dose per fraction, which we know is something extremely difficult to do in large volumes. So the immediate next question is, how can we maintain this flash sparing effect in large volumes? And do we have data on that? We have data in Lausanne, but not really published, so I'm not going to mention that. And this is certainly a very important question. So the next question is the flash sparing effect compatible with fractionated radiotherapy? So far, what we've seen is that we see more flash sparing effect with high dose per fraction, at least above 10 gray, certainly where we can start to see it. Maybe a little below, but big dose per fraction, more likelihood to see it. Here, it's a diagram, a graph, which is derived from Pierre Montegruel, regarding the neurocognition in mice after 10 gray brain total brain irradiation. And what we see here is that there may be some suggestion that there is a window of opportunity here of treating this, of having the sparing effect in the range of 7 to 10 gray in fractionated mode. And if you go beyond that, you are too toxic, whatever you use, conventional or flash. And if you are below that, when you fractionate, it's hard probably to see a difference also between flash and conventional. This is an interesting piece of work, which I have used fractionated irradiation on rat glioblastoma, where they scored the toxicity and the tumor control with different regimen. And from this study, which is using a very high dose rate, as you can see, 2 gray per pulse, very few pulses, high dose rate in the pulse, it's hard to see a difference in the frame of this fractionated irradiation. So the immediate question about fractionation is, if the flash sparing effect is seen at high dose per fraction, how usable, how doable is it in clinical setting? And this is again a very important study which has been submitted from Lausanne and Zurich. And well, we tested in a randomized clinical trial 30 gray, 20 milliseconds, single dose with hotspots. We have to say there were hotspots up to or beyond 40 gray. And it was compared to a sort of conventional irradiation in cats, which was previously shown to be very safe and very effective. So here, what do we see in terms of toxicity? In fact, there was more late necrosis in the single dose flash irradiation compared to the fractionated irradiation, which may not be a surprise because if we are using very, very big dose per fraction, we may have late toxicity. So what we can conclude from this study is that the ultra high dose rate does not fully compensate for the lack of fractionation. And also because we had hotspots, more than 40 gray, and for the suboptimal conformality. That means that ideally, if we want to use flash in the clinic, we should probably try to see whether we can fractionate and obviously keep using optimal conformality while we are treating with flash. So compatible with fractionated radiotherapy, we don't know, but it's a very important issue. And the next question is how compatible all this is with high precision radiation therapy delivery, which we know normally requires a lot of beams. So if we have a lot of beams, we decrease for each beam the dose per fraction. And then we may lose the flash effect. So that's where it's difficult probably to understand how to use flash. And clinical translation has started with, there are at least two studies, one with electron, one with proton, but they have both limitations. Electrons can only treat with flash superficial targets, and protons, also small volumes at the moment, with single beam directions. So it's a little bit archaic way of using radiation therapy in both cases. So compatible with high precision radiotherapy delivery, we don't know, but it's certainly a very, very important issue for the future. So now, if we just try to summarize, for clinical use, the flash effect has to be robust and reproducible. This is probably the case. Now, for the other question, it's more question marks that we have at the moment rather than answers. And among the most important aspects that we need to understand for clinical translation is what about the optimal parameters? What about the optimal parameters, and especially do these parameters work in large volumes? The other question, absolutely key, is the compatibility of flash with fractionated radiotherapy. And whether we are going to gain, I don't know, 10% each fraction or not, we don't know. And finally, how compatible is flash with high precision radiation therapy delivery? And here we are more in a technical problem where we need really to have flash plus high precision radiation therapy. And it's very difficult to achieve technically. So just a few words on the clinical trials that have been initiated. So the first one is from Cincinnati, treating pediatric cancers with a palliative intent, a palliative dose of 8 gray, which showed the feasibility. I think 10 patients have been accrued. The other set of clinical trials is from our institute in Lausanne, where we started the Impulse phase 1 dose escalation trial. And we have another trial, which is a randomized flash versus conventional radiation therapy, which is going to start soon. We have also an intraoperative flash electron therapy program, and we have also a flash, very high energy electron for deep-seated tumors. And at least what we explore in the first trial is this range of dose between 20 and 30 gray, where we can start having a very nice dose modifying factor. In fact, we don't know, but it's possible. And then it's really a range of dose that is worth testing in patients. So the IMPULSE trial is dose escalation for melanoma skin metastasis. So we've 7 patients entered at the moment, and 2 cohorts, one with large and the other with small fields. So this is the project that we have with CERN for flash therapy with very high energy electrons. Just starting now. And these are the conclusions. Clinical application for flash therapy. Certainly the conclusion is temporary because we are really just starting to try to use this in the clinic. So from the preclinical data, I think we can say that the results are promising and consistent. A lot of questions on mechanism, on tumor cure. Is it going to be confirmed that we have the same tumor cure? And combination with drug also is an issue that we need to address. Optimal parameters for a flash effect. That's the second question. At the moment, we started using the parameters which have been associated with flash in preclinical setting, but they are maybe absolutely not optimal. We don't know. And we don't know also what about the best parameters for large fields and what about the parameters also for fractionation. Beam control diagnostics monitoring, at the moment, we can say it's safe for the first clinical testing, but certainly we need some improvement there as well. And finally, the clinical translation. I think the proof of concept that can be used in patients is starting to be tested, at least in superficial tumors with electrons and also with deep-seated tumors with protons. But as we've said, there are numerous technical challenges. Both having flash and high conformality together is certainly a very difficult challenge because we would need to do IMRT or IMPT in less than 100 milliseconds, which is something not trivial to achieve. And this is to acknowledge the team in Lausanne, Professor Wozner, you probably all